Noted? Noted? Okay. Okay, the committee's report, Stimulating Enterprise and the Economy, was published last Friday. I want to thank members in the Secretariat for their considerable efforts in getting it published. Thank you very much for doing that. A report on Covid-19 in nursing homes will be circulated to members tomorrow, and we'll consider it in a Teams meeting on Thursday. And as we know, we have an early draft of the report currently with the working group. And we'll have 2 reports to consider next week on testing and tracing and an interim progress report. I'm going to chair the first session today. And just, I see we're all wearing our masks. I think the guidance is that we wear it while we're in the chamber, but not while making a contribution or speaking, which is fair enough. And I'm here behind a screen. And I welcome our witnesses who are in Committee Room 2 this morning from Forsa Trade Union, SIPTU and the Irish Nurses and Midwives Organisation. I wish to advise the witnesses that by virtue of Section 17(2)L of the Defamation Act, I realise I'm wearing that while making a contribution, witnesses are protected by absolute privilege in respect of their evidence to this committee. If you are directed by the committee to cease giving evidence in relation to a particular matter and you continue to do so, you are entitled thereafter only to a qualified privilege in respect of your evidence. You are directed that only evidence connected with the subject matter of these proceedings is to be given, and you are asked to respect the parliamentary practice to the effect that, where possible, you should not criticise nor make charges against any persons or entity by name or in such a way as to make him, her or it identifiable. And so we'll begin with the Forsa Trade Union. Ms. Keogh, could I ask you to introduce your delegation and make a short comment outlining the key points of your submission to the committee, which your submission having already been circulated to members?
Good morning. My name is Catherine Keogh. I'm an Assistant General Secretary in the Forsa National Health Office. I'm here with Eamon Donnelly, who's our National Secretary in the Health Division. You would have received our submission in advance. The key point for Forsa this morning is I suppose the ripple effect that the infection rates across healthcare workers have had across the whole health service. As we faced into the pandemic, Forsa represents health and social care professionals, so we would represent physiotherapists, orthoptists, speech and language therapists. So, for example, our orthoptists would have gone and got trained in swab testing, would have gone onto the front line and would have been swab testers. We've examples of people then getting infected with COVID, being off work for 3 months and then returning straight back to frontline testing. So I suppose we want to talk today about the huge effect that had across the health sector, primarily for our own grades, but also for all grades, because I suppose an oft refrain of the trade union movement is an injury to one is an injury to all, but in healthcare circumstances, particularly in a pandemic, an infection to one has an effect on everybody in the acutes and the community. Our submission reflects on that, or reflects on the rates of infection. I might pass over to my colleague Eamon Donnelly, who has some opening remarks to make.
Yes, well, in addition to what's in the statement, I think one of the key points that we want to emphasise is it's not just about the disproportionately large infection rates among healthcare workers. It's about the effect that that has across the workforce in the health sector. So, for example, we move, or at least we hope we move, from a world where we were dealing only with the response to the pandemic into what they call in the HSE a co-COVID environment. So we are now living with the disease and we are reopening health services that people need access to. You can't keep health services shut down forever. So what that means is that community-led health services, as they reopen, the people who, as my colleague Catherine Keogh has referred to, have already been working in direct response to the pandemic, now go back to substantive roles in the community. And I can take an example, and it's cited in the statement, of a physiotherapist who will now have to pick up treatment with somebody whose mobility has deteriorated alarmingly in the 4 months that have been down.
Thank you,
since the COVID response.
Thank you. We do have your opening statement, and I want to try and get to the others, so we'll certainly come back to you. So thank you very much. And if I could now thank Mr. King for coming this morning, and may I ask you to introduce your delegation and make a short comment outlining the key points of your submission to the committee, recognising that we have had it already, of course.
Okay, thank you, Chair, and good morning. As you know, SIPTU, we have approximately 43,000 members who work in the health service across a multitude of health service settings, and we represent a very broad range of worker right across the health service, from porter and attendants to kitchen staff, and so on, into areas such as the professional grades, people working in chefs, ambulance and paramedic staff, radiography, so on, nursing and midwifery, and some members and quite a significant number of members in the mental health services. We did, Chair, as you are aware, we made a detailed presentation to you, which also includes the findings from a key or the survey of our membership that was undertaken. And I am joined today on my left by Michelle Monaghan, who is the SIP2 Honorary Vice President, who was also a frontline worker employed in the HSE, and Michelle can give direct evidence to the committee on the effect of the crisis on healthcare workers. Whilst the submission presents the findings, it also does make a number of key recommendations, and we do look forward to discussing or engaging with the committee on this today. And some of that would include the likes of a comprehensive review on the effects of the totality of the impact of the crisis on healthcare workers affected, but also on the staff who weren't affected but who were left working in that pressurised environment, and so on. We do also believe that there's significant learning that needs to be done from some of the policies and decisions were taken, so as to ensure we don't end up in this situation again. Some of that would include the likes of the decanting of the acute patients into nursing homes and so on.
Yes.
We do need. Yeah.
I might stop you.
Am I on time?
My apologies for cutting across you.
Okay, that's fine, Chair. Thanks.
Thank you, and welcome back, Ms. Nihey. Could I ask you to introduce your delegation and make a short comment outlining your key points, recognising that we, of course, have it?
Good and good morning, committee members. The INMO submission today will focus on matters that were briefly touched on previously during the childcare submission, which is the high rate of infection among healthcare workers. Currently at 34% of all of those who have been infected with COVID-19 in the Republic, of those 32% are healthcare workers, and of those 32% are nurses and midwives. We believe it is time for the Health and Safety Authority to be involved. We believe that an examination of the high infection rate among healthcare workers must be examined by the statutory agency that is tasked with this particular responsibility, and it is unfair and it is disrespectful to healthcare workers when they have not been given the statutory authority to investigate the cause and also to recommend the reasons why we have to do better. Today, accompanying us is staff nurse Siobhan Murphy, who herself has been infected with COVID-19. She's currently on week 14 of an absence from work, and she has had severe side effects as a result of being infected at work. We know that 80% of all of infections within the healthcare setting have been occupationally acquired, and we have also surveyed our members. And we now know that their biggest concern is that, as you know, the pandemic still is within our health service, and the idea that they have to face it again with the current level of support is something that absolutely terrifies them. And I just hand over to Siobhan for 1 minute to give her personal circumstance.
Thank you, Phil. So yes, I work on a COVID positive ward since March 24th. We were catapulted into this pandemic, but we faced it with strength as a team. We are nurses who work 13-hour shifts. We work days, nights, weekends. I suppose my experience was overexposure and burnout due to the challenge that we were faced already pre-COVID with understaffing and overwhelmed with the ever-expanding role of being a staff nurse. You cannot put a time limit on providing care to a patient, so I suppose the exposure that COVID-19 as a nurse was profound for us, and there's been psychological and physical side effects and symptoms that I'm still experiencing today. I'm still off work at the moment, as are 3 of my colleagues, and 4 colleagues were required hospital treatment due to contracting COVID-19. 13 of 20 of my colleagues contracted COVID-19.
Thank you for being here today with us, Ms Murphy. We appreciate your attendance. Thank you. And I'm going to move on now to the members and contributions from the members and remind them that they have, I think, Fianna Fáil first, Deputy Devlin, and you have 10 minutes for questions and responses for witnesses. And just to make witnesses aware that it's sometimes difficult to communicate between the two rooms, so you might hear the Deputy just speak across you, and they're only trying to keep things going. Okay, so Deputy Devlin.
Thank you, Chair, and thank you very much to the witnesses for your attendance today, and particularly to Ms Murphy for your personal account. I suppose, like the public at large, we appreciate all that you and the staff and your members do daily, but particularly during this crisis. And, you know, there were obviously a lot of challenges in advance of COVID, but certainly during COVID, and I think your submissions have articulated that very well. I suppose for me, the million-dollar question is, and particularly in the face of a second wave, God forbid, but if it were to come, what can we do differently and how can we do it differently? And I'd be interested to hear from the various organisations here this morning, please, as an initial question. So maybe the INMO, maybe, or...
What can we do differently? We can ensure that healthcare workers have the same status as every other worker in the Republic, which is that if they go to work and because of the job they do, they become ill, they have the right to have that examined by the statutory agency that holds responsibility for any other workplace accident, which is the Health and Safety Authority. So this committee, we would urge this committee to ensure that the Health and Safety Authority, that the regulation that prevents it from doing just that, that is altered and that is changed, and that the Minister with responsibility puts before the House the regulation changes. It's very simple, it's a statutory instrument, and it needs to be done immediately, because there is no way that an employer, either in the public or the private sector, is the only authority that determines whether or not they've acted in a correct manner when it comes to their workers' welfare. We don't believe that should be the case. We don't believe it's fair on healthcare workers. We appreciate, and we've said this publicly previously, the applause and the very well-intentioned thanks to healthcare workers. But right now, facing into doing this again, what our members are saying is they are exhausted, they can't face a second, the idea that they would have to endure this again with the protections that were in place, and that needs to be examined by the Health and Safety Authority to ensure that correct protections are put in place.
Thank you. Any other organisation there have any recommendations of how we might do things differently?
Go ahead, Eamon.
Yeah, I think as well as that, I agree with what my colleague Phil Nihaya has said in terms of the burnout. But if we do get a second wave, it's going to be very difficult to call on the exact same cohort of people to provide the same response. And I wonder, all of the excitement that was announced with Be On Call Ireland, that's now being stood down. To my mind, we're not going to be able to deal with a second wave without the ability for a fluid migration of the workforce into the health services. And we have to be upfront about that, because we're in a better place to be able to deal with a second wave in terms of testing and tracing and all of that type of thing. But the workforce in health, for the reasons that my colleague has outlined, you know, they're pretty much at burnout stage. And the last point I'd make is the HSE needs to be right up at the front of the game in terms of making sure that the health services are compliant with the safety protocols on return to work, and they aren't. They're behind the pace on that matter.
Thank you, Chair. I'll be brief, and I'll try to avoid being repetitive, but I do want to agree with my colleagues on the importance of the statutory agency assuming the required levels of responsibility. I mean, the fact of the matter is the figures stand up for themselves. There's no other section of employment that has suffered the same infection rates. And the reason why they're here is because they work in HSE and healthcare settings, and therefore the HSE need to be involved in making sure that all that is done, or all that can be done, is done to protect healthcare workers in their employment. I would just make one additional point, if I can, and it's this. As a society, we waited for the pandemic to be here before we reacted. So I do think we have an opportunity now, while it has abated to the extent that it has, to make sure that the policies and procedures that we implemented very, very early on aren't repeated, because in some cases some of those policies and procedures did not help with the level of infection rates that occurred, and I do think we have that opportunity now.
Thank you, Mr. King. Can I just ask, just in relation to your own submission actually, because it's caused a bit of a flurry in advance of this morning's meeting, and that was obviously about certain workers presenting for work with potential symptoms and in fear of losing overtime or premiums. To me, I find that quite worrying, and I'm sure the public would as well. How widespread was that?
Okay, well, look, I think this is something that we raised extensively both with the HSE and with the relevant department when this particular policy decision was taken. And to understand the point that we're trying to make, we have to go back to the context of what COVID was like in healthcare settings back in February and March, where there wasn't the advanced levels of testing and so on that there is now. The reality of the situation is that people in the health service, as they do in other sections of the economy, require their total earnings to be able to survive. The point that we were making in relation to putting it into the submission was just to draw the attention to that it was a policy that didn't work because it served as a disincentive. So it's not the question of trying to be how many or what prevalence. The fact of the matter, Deputy, is that it was a policy that didn't work because it acted as a disincentive.
Okay. And obviously, if there is a second wave, we need to be very conscious of that, because certainly from my perspective, the message would be that if anybody shows symptoms, irrespective of any monetary gain, that they don't present to work. And I would hope that you would share, and all the committee members and indeed the witnesses would share with that view. I know obviously there are financial considerations and that's a legitimate concern, but surely health would override that, and good luck in your discussions with the HSE. And then finally, if I have 2 minutes, Chair, if I could just ask, in terms of the discussions between the organisations that the witnesses represent and the HSE, I presume they're ongoing in the face of a second wave. Could the members maybe elaborate on that, please, for us, please?
Chair, the discussions are ongoing in respect of opening up the health service to COVID and non-COVID services. The problem is that we are yet awaiting a funded workforce plan. It's something we've sought. It needs to be put in place. We have guarantees, for example, that both services will have to be provided. We have sought that the workforce reflects that. So, for example, if I'm a nurse in ED tonight, I will be providing a service, either COVID or non-COVID service, but there aren't two of me, but there are two services, and that is for the very reason that you just outlined previously, because the important point of this virus is it doesn't discriminate. Its aim is to infect people. So therefore, we have to make sure that we prevent doing that. And if that means that some of the workforce have to remain outside of the workforce, the health service have to make provision to supplement the remaining workforce. What happened during the recent times is that there was nobody to call upon, and therefore those that were at work were working short. And Siobhan here will give testimony to that. On her ward, there were 19 nurses. 12 of them got infected, and 12 of them were absent from that ward. But the patient load did not decrease. Therefore, we know from the WHO stats that infection rates are higher among those who are fatigued. So the nurses that remained on that ward obviously were exposed to a higher risk of infection purely because of fatigue. So we need a funded workforce plan for nursing and midwifery. The Fianna Fáil submission pre-government looked to increase the workforce quite substantially. We are very eager to have that conversation. We're meeting with the Minister this afternoon, and we will be raising that with him as well as raising it with the HSE. That is the public sector. We then have the private sector, and we know that the workforce collapsed very quickly because their baseline is insufficient sufficient to begin with. So we have to look really seriously at reintroducing the public provision of care of the older person. We cannot rely on the private sector to the level that we have done. 82% of all care of the older person services provided in the private sector, and the workforce are not sufficient to endure another flu or another wave of Covid-19. It is simply unfair, it is inhumane to ask them to go back to that level of crazy staffing. It's just inhumane.
Thank you, Ms. Nehay. Thank you, Deputy Devlin. We move on now to Sinn Féin, Deputy Cullen, and you have 10 minutes.
And can I welcome all of our witnesses? And if I can start by saying that it's almost impossible for us in the 10 minutes we have to go through all of the submissions. I'm sure all of the contributors will find the same problem. There's so much that can be said, and can I thank you all, first of all, for your very comprehensive briefing notes and opening statements that were provided, and also to take the opportunity to commend all of your members and the frontline staff across all of our healthcare settings for the huge sacrifices and work that was undertaken over the last number of months. Can I start, first of all, Ms Nehay, with your organisation's briefing note that was sent to this committee? And just first of all, the number of Covid-19 rates amongst healthcare workers in your submission, you talk about the international average, so it's 1% in Singapore, 12% in Italy, 15% in Mexico, 22% in Spain, and 32%, one of the highest percentages in this state. Can you first of all explain to me from your perspective why it was so high in Ireland compared to other countries?
Well, good morning, Deputy. The figures we cite are figures that have been collated by the International Council of Nursing, and they look at the numbers of healthcare workers infected as a proportion of the overall infection rate in that country. Now, there are some caveats attaching to that for obvious reasons. However, we're satisfied that the figures we've received from the HSE reflect the reality. So, for example, the most recent figures collated last Friday show us that 8,347 healthcare workers have been infected with Covid-19. Of those, the highest single group are nursing 2,711, and we've experienced that on our wards, and Siobhan Murphy, who's here today, experienced it personally. So the point is that the reason is there's a number of reasons. One was we had a deficit of PPE to begin with. That has improved. That's no longer the issue. The biggest single issue is fatigue and the length of exposure of the healthcare worker, in our case nurses and midwives, to those with the infection. So the longer you're exposed to somebody with the infection, the more likely you are to become infected yourself, and that has proven positive. So we have to look at the idea that we open up COVID wards. We have 19 nurses working on that ward, 12 of them get infected, and we have no replacement. It simply doesn't make any sense, and it is actually causing the infection to increase.
Okay, and you also go on to say that in the survey that you carried out, 73.25% of respondents stated that they found difficulty in assessing PPE. I think people would find that extraordinary that it's that high, and obviously I'm not disputing that it is the case, but what time period here are we talking about? So, like, what was the critical time period when staff most found it difficult to get the PPE, and has that issue now been fully resolved?
There was great difficulty with getting PPE to begin with, particularly in the private sector. The biggest issue with PPE that we found was the wearing of face masks. And as you know, there was a lot of debate around whether we should or whether we shouldn't. But on the HSE did not introduce a policy until the 22nd of April, which made it mandatory to wear face masks in healthcare settings. And I gave evidence before this committee previously, and in our survey again, nurses give testimony to them being instructed not to wear face masks. And that was simply the wrong policy. We knew from international evidence that it was incorrect. They were instructed not to wear face masks. One nurse was actually disciplined for wearing a face mask. We now know, thankfully, that face masks do contribute to the protection of healthcare workers, particularly, and there are different grades of face masks. So obviously, if I'm working in an intensive care unit or I'm working in an area where I am engaging in aerosol generating procedures I have to have a higher quality of face mask. But all of that was too late. 22nd of April, following the unions in this room requesting and constantly asking the HSE to change their policy. Eventually they did on the 22nd of April. It was very late, and Siobhan and her colleagues were working on a COVID ward from just after St Patrick's Day. So the point is PPE was a big factor. It has improved, definitely has improved, but the fatigue and the exposure, we cannot risk that again.
Okay, I might put a number of questions now because I'm going to get caught on time and I do want to cover as much ground as I can. I have just a final question for you, Ms Nihey, which is specific to you, and then I have a general question then for maybe all of the witnesses to come back on if they can. And my final question to you, Ms Nihey, in relation to the survey, and it reads, you know, it's very distressing reading when you're reading what happened to frontline workers, it has to be said, and we don't have time to go over them all. But I'm just referencing one there where one respondent stated, returning to work does not mean 100% recovered, and employers should learn to accommodate staff returning from COVID special leave and to support them to get back in shape instead of pushing them even more. It goes on to say in your opening statement and in the submission that a long-term process will be required in dealing with the psychological impact that all of this has had on nurses and frontline staff. It is at this phase that many staff will be running on empty, and it is important to be able to respond to the needs of staff and to support them. And in any new surge that the virus emerges, the health service must have the workforce to deliver services and adequate supports. So can you just maybe outline to me specifically, Ms Nihey, what needs to be done to support frontline workers, whether it's because of the psychological impact, the physical impact, or whatever, what practical supports in the here and the now would be needed? And then my general question then to all of our witnesses, I'm not sure if you saw the sessions that we had last week with the HSE where we were talking about capacity and the obvious fact that on the one hand, we have to still deal with COVID in our acute hospital settings. There may well be a surge, but even with the levels that are there, it requires obviously a lot of attention from frontline staff. We then have all of the ongoing non-COVID care. We have the catch-up programme, which is obviously necessary as well to catch up on all of the missed care. How is any of that going to be done with the current capacity what's there? It just can't be done. So maybe today if you could give us, all of you, your view on exactly in the short term what's needed in terms of beds, in terms of staff and in terms of other supports, whether it's physical infrastructure, what's needed in the next number of months and indeed in the next year in our health service to ensure that we can, yes, deal with COVID and all the non-COVID care and have some chance of dealing with the catch-up programme. I know it's a general question, but I think it's an important one in terms of what's needed in the here and the now. So the specific question was to Ms Nihey in relation to the survey, and then that more general, broader point on capacity to the other witnesses if they want to take it as well. Thank you, Chair.
Well, again, Deputy, in the here and now, the respondents to our survey made it very clear that a telephone helpline is not sufficient. They want practical post-traumatic stress support. They describe what they are now enduring as post-traumatic stress. They are saying that they are fearful of the ability of their employer to keep them safe, and they are also quite determined that they will work, that they are happy to go to work, but they have to be protected. Again, we call on this committee to look to the Health and Safety Authority, which is the statutory body with responsibility to ensure that workplaces are safe. We have to have that comfort. The people we represent, who were to the forefront of keeping citizens of this country safe and making them better. And I think the figures from our intensive care and the recovery from this pandemic are down to the good work of those healthcare workers who spent their time beside the patients in those beds, making sure that they recovered. And it is really important that we don't forget that. And I think right now what we need is the assurance that there is somebody other than the employer determining that the workplace is safe. That is imperative, and this committee has the authority to make that recommendation, and we would call upon the committee members to do so.
Okay, and then I don't have another question. It's just a general question about capacity that's needed in the here and the now for maybe all of our...
Deputy Cullinan, if I can maybe come in there. I'm a radiography manager, so I deal with capacity issues every day. And what's going to happen is we have two pathways, as Ms Hay said, but we've reopened EDs. EDs are now at the capacity they were pre-COVID. Pre-COVID, we had trolley guard, trolley weight, trolley everything, except you're not allowed to have that anymore. So what's putting back on the staff is work two streams, sometimes with one piece of equipment, one CT scanner, one MR scanner, but can you put your COVID and non-COVID patients through them as fast as possible so that nobody's waiting on a trolley, so that patients are admitted quickly, so there is no crossover between COVID and non-COVID. We're not nearly at burnout, we're at burnout. You had to be there, you had to be working through it, and as Siobhan will attest, nobody can get what you had to go through to be there. The first thing you learn as a healthcare professional is to leave the emotions at the door and don't take it home with you, don't take your patients home with you. But we did, we took every patient, every COVID patient we took home with us because no family was allowed in to see them. And the burnout, the stress, the fatigue for those who didn't get COVID but had to do double shifts, additional call, additional everything, they need to be recognised and a response needs to be put in. In one word, what do we need to meet the capacity? More. More staff, more equipment, more space, more everything. Otherwise, it's not going to work.
Thank you, Ms Monaghan. Thank you, Deputy Cullinan. Now move on to the Fine Gael. Deputy Burke, please, for 10 minutes, I believe.
Thank you very much. Thank you indeed to all of the people who are here this morning, and thank you for the submissions that you've already made, and for the work that has been done over the last 4 months in particular. Could I just raise an issue which is from the HSE report about the breakdown of healthcare workers? One of the concerning figures that I have is of the 8,260, and I know it's gone up slightly from the 8,260, 2,878 of those identified with COVID had underlying clinical conditions. I'm extremely concerned about that, that a person working in the HSE who was who had an underlying medical condition then appeared to have been put in the front line. And I have evidence of that because I had a number of people on to me over the last 3 to 4 months where people were looking to be assigned to other areas rather than in the front line dealing with COVID. I'm just wondering, was that issue taken up by any of the unions during the course of the last 4 months with the HSE, where staff who had previous medical conditions were now required to work in the front line again, where they were a high-risk category?
Well, if I could deal with that, because we were involved in the negotiations at that time, and I must say that the HSE took a very severe position on that issue, Deputy, insofar as they required consultants' certification that somebody had a vulnerable condition, and if you didn't have a certification by a consultant, you were just asked to continue as normal, otherwise you were off pay. So the practice of ignoring a general practitioner's validation that you had an underlying condition, that seemed to present a huge problem, and it's no surprise that a number of the workers who were infected now turn out that they had underlying conditions. But I think everybody needs to understand that when the outbreak happened in March, we were told that our workers were an army, and there was a command and control model put in place to mobilise the workforce to deal with the pandemic on behalf of the citizens of Ireland. And that's what happened. However, you can't sustain that in the long term. You can't close down community health again. And when you talk about the capacity issue, that's why I say we need a migration inwards in the workforce. But it's no great surprise that the number of infections comprised of the vulnerable worker category because of the severe stance taken by the HSE in that regard.
And I just ask, you know, of the 2,878 is quite a high number who are underlying. Are you aware if some of those people had previously requested not to be assigned to the particular role they were asked to take on?
amount of those, Deputy. But you see, there was a prescribed list of what they would call a vulnerable worker, and it was really heavy-duty stuff such as cancer treatments and so on. The stuff like blood pressures and diabetes were disregarded.
Okay, but I know, for instance, of someone who had previously gone through treatment for cancer, was but now back working in the HSE, and was still required to be in the front line, and 2 or 3 of those cases. I mean, did you come across some of those cases where people who had medical conditions clearly indicated to management that they felt inappropriate, that it was inappropriate for them to be now in the front line again, and management ignored that request to be assigned to other areas?
Yeah, I think it'd be wrong to say management ignored it. The policy ignored it. The policy that was handed down to managers ignored it. It ruled it out.
And who are you saying the policy came from? I mean, are you saying that HSE management, or are you saying the Department of Health?
I'm saying the people who were in charge of the command and control set down a policy of public health guidance, and that's a composition of all of the people from the Department of Health, from NEFET, from the HSE. They set down that policy, and the policy on vulnerable workers, as far as we're concerned, didn't go far enough and has resulted in the high number of infections that you've outlined.
Can I move on to the issue in relation to the wearing of face masks? Because, again, at a very early stage, I received quite a number of emails from people who were on the front line who wanted to wear face masks, and the decision appears to have been taken at a local level that staff, and I'm talking about local level now, I'm talking about individual medical units or nursing homes or whatever, that masks were not required. Was that your evidence that you received, that where people made the requests, that again those in charge of the particular ward or the particular hospital or the particular nursing home were ruling against it, rather than any diktat coming from a central level of HSE?
If I might answer that. Good morning, Deputy. The policy of the HSE was quite specific about the wearing of face masks, and it wasn't broad enough, so it was the policy. And the policy was quoted to nurses when they sought to wear face masks, when the wearing of face masks in the particular setting that they were in contravened the policy. So what we had to do at national level was change the policy. And as I said earlier, the policy was changed on the 22nd of April to allow the widespread wearing of face masks, which should have been the case from the beginning. In respect to the underlying health conditions question that you posed, healthcare workers got infected because of the exposure rate. Healthcare workers, no more than any other section of the population, obviously some do have underlying health conditions. The biggest issue we faced was nurses who were pregnant and who were attending work, and we had a battle to ensure that they were not exposed because, again, pregnancy was not considered an underlying health condition. The fact that if you are pregnant and you contract Covid-19 at the high rate, 34% of nurses, 34% of all of the healthcare worker infections were among nurses. Treating a pregnant woman with Covid-19 is very difficult and should never even be contemplated. And we did have a huge problem in trying to get redeployment of pregnant nurses and midwives from the front line. That was a problem. The problem is exacerbated because your underlying staffing levels do not support redeployment. We had also a call from the private sector to redeploy public servants, nurses and midwives particularly, into the private sector when they were short in the public sector, into the private sector where PPE was a problem, where policies, procedures, etc. were absent, unfortunately, in some cases. So the exposure of healthcare workers, that's the point. The point is this cannot be left to the employers. This has to be looked at by an agency with statutory authority to examine it. Because the employer constantly saying this is the reason and this is the reason, that simply is not good enough. We have to have stronger and better protections that are based on a legislative basis for healthcare workers. They deserve the same as any other worker in this country. They shouldn't be treated less favourably.
Can I just move on to going forward from here? Over the last 6 years, from December 2014 to now, the number of people working full-time in the HSE, and that's whole-time equivalents now, has gone from 103,000 up to 123,000, which is an increase of 20,000 staff. Where, obviously, that's across all areas, from management to administration to care assistants to nurses to doctors. Where now should the priority be in relation to recruitment at this stage? Is the priority, should it be care assistants and nurses, or again, is it across all areas that there should be an increase? And the kind of the issues that arises then is, what kind of numbers should we be planning for over the next, say, 3 years? Because it's something obviously you can't introduce overnight, but over the next 3 years.
Thank you. Yeah.
Numbers of healthcare workers, the health service has increased in capacity. The busyness of the health service in comparison to that figure that was in place when the last recession, when the answer to the last recession was introduced, a moratorium on recruitment. A moratorium was introduced in May of this year and really interfered with the ability of people to stay safe during this pandemic. There's just no other way of saying it. You cannot cut back on frontline staff in a service that is delivered by people. And we have a shortage right now that is estimated at just under 5,000 nurses and midwives. We know from the maternity strategy, for example, that we are providing maternity services that are now, we should have one midwife for 29.5 births. We are close to 37, 38 at best in many locations. It's a known fact that we are short of midwives. It's a known fact that we are short of nurses. Each of the political parties in their pre-government, in their manifestos stated, Fianna Fáil said 4,000 extra nurses were needed. Fine Gael said 5,000. So this is known. We know that we need more frontline healthcare workers. We need more nurses. We have to do everything we can to retain those that have come through this pandemic so they don't leave. And we also need to recruit more. We need to increase undergraduate places. 5,000 school leavers looked to do nursing last year, and 1,700 places are available. That's a quick one. Yeah. And undergraduate places should be increased.
But over the next 3 years, what kind of numbers are you talking about in real terms? Are you talking about how can you fill that kind of number of 5,000 over a 3-year time period? Because that's the kind of time period you're talking about.
Yes, and we believe you can. You have to have a funded workforce plan based on the science which says patients do better if you have 80-20 skill mixes in an acute hospital and 70-30 outside of the acute hospital. That's what the science tells us, and the numbers have to reflect that. Otherwise, you're saying it's okay to base our figures on unsafe levels of care. We don't accept that.
Thank you, Ms. Hay. Thank you. We now go to the Labour Party. Deputy Smith, please, for 5 minutes.
Thank you, Chair, and thank you to all the witnesses for their really detailed submissions. There's so much in them. I wish not only that I had more time, but that our committee had more time to interrogate everything that needs to be interrogated. But just, I hope you'll forgive me for just picking out a couple of issues from one of the submissions that caught me, and it's the quotes from the SIP2 submission from members who. One of the quotes is, at times there was rationing of PPE that you're made feel guilty for asking for it. Another one is that now it's very difficult to access hand sanitizer and masks. Now it's difficult. And that PPE is locked away in a manager's office, and if the manager isn't in, it runs out. I mean, these are quite shocking quotes to be reported back, given the assurances that we've been given from the HSE and government that all stocks and provision of PPE for all frontline and support staff, that this shouldn't be an issue anymore. And it seems to me that this is an issue. So just, I'd be interested, I suppose, Michelle, in your work as a radiographer, just based on that submission, if you could just give us maybe more detail of what you've experienced or what you're experiencing right now. I know you touched on it in your first contribution. And then to Mr. King, just you mentioned at this outset that you represent a broad spectrum of staff. What learnings, further learnings, can you take should we have a second wave or a further wave of this?
Thank you, Deputy. I have to say the PPE situation has evolved. The initial 3 to 4 weeks were a nightmare, but that's well documented. What came from China The large would fit a small person, so some of us had no hope of getting into them. So that was a huge issue for staff. The hand sanitizer, everything, I think it's reliance on a single source, so that everything came from one place. So when that place couldn't supply it, there was no other suppliers. So the market just became overcrowded because the whole world wanted the same product. I work in Connolly. We had a very, very good team, so we were not left without anything at any time. We distributed through wards. We became a team. If you were running low on something, you went to somewhere else, and everybody worked together. I do know from my colleagues around the country that it did happen, that things were locked away, that you did have to go up and beg for your PPE, and that's just not right. The staff working through this pandemic, the least they required was the ability to do their job in a safe manner, and that was denied an awful lot of them. And that puts pressure, stress, and the fact that they don't want to go again. And it also, there were panic attacks at work. There were full-blown panic attacks from people who felt they could not go because, as radiographers, we do portable x-rays on every COVID patient. And to do that without maybe not having PPE when you got there, people just can't cope with that again. And so going forward, we really need to look at the learning of this. We really need to look after our workers, those who get infected, those who are post-infection, and those who are left behind, who are working double shifts, triple shifts, going into places where they don't normally work and pick up the slack with a skill set that they have to learn on the job. So the whole thing, we need to learn. We need to learn quickly, and we need to have that report and statutory backing of everything that happens, because we can't face another pandemic and address capacity at the same time.
Thank you, Michelle. I really appreciate that. I just have less than a minute left. Mr. King, if I could get an answer to my question, I'd appreciate it.
Okay, thank you, Deputy. I will be brief, and I'm going to avoid repetition if I can. Look, I think I mentioned earlier on briefly that as a society, as a health system, we waited for the crisis to be here before we reacted. I think we're in a position now where we don't have to allow that happen again. So I do think, you know, very broad kind of answer, it is about our state of readiness to be able to deal with the second surge when it comes. It is about ensuring that the health services has the capacity and the resources available to it to be able to meet that challenge when it comes. That includes all kinds of things like PPE and proper policies and procedures that don't, in some cases, act as disincentives, and clear decision-making authority and so on. Obviously, the issue in relation for the role of the Health and Safety Authority has been made, so I won't be repetitive there. But just on the issue in relation, so one of the issues around resources includes staffing. And include staffing in all areas and safe staffing in all areas. And one of the things that our submission highlights, and it's just for the purpose of highlighting it rather than the story itself, because out of the story we must learn, and then it's how about we apply that learning. So we have thousands of workers who come into health services settings every day of the week to do essential jobs to support the safe delivery of health services, who are not public servants, and they don't have the same protections, terms and conditions of employment, including the likes of death and service benefit, health and safety entitlements and so on. And we do think that that also needs to be examined if we're talking about a safe delivery of health system going forward. Thank you, Chair.
Thank you.
Thank you, Chair.
Sorry, we're quite out of time. Deputy Short, all you 5 minutes.
And thank you to all our visitors for your presentations, but more importantly, thank you for all of the work that you and your members have done over the last 4 or 5 very difficult months. And condolences to you on those members who you lost in the line of duty, and indeed the many of your members who are still suffering the effects of the COVID infection. And while the point has been made earlier that thanks is important, and that's a heartfelt view, I think, shared by the whole country, The way we give effect to that in meaningful terms is to introduce protections for workers in both ways. I think it's quite remarkable that COVID-19 is not a notifiable disease. I mean, this has only come to my attention recently, I have to say, as a result of the campaign being run by the Congress of Trade Unions. And it is just incredible that, given the deadly nature of the virus and the fact that it has had such a devastating impact on healthcare workers in particular, that there has been a reluctance, to say the least, on the designation of COVID as a notifiable disease. Now, I note what has been said here about the Congress of Trade Unions making an approach to the Taoiseach, and I think it's unfortunate, to say the least, that that hasn't been responded to positively. And it's certainly something that we as a committee will take up in producing our report and recommendations. But I just want to ask Ms Nihey in particular, where are we at just in relation to that campaign to ensure that it is notifiable, noting that the Taoiseach has not been encouraging so far, but are you engaged in discussions at any level in government in relation to this campaign?
Good morning, Deputy, and thank you. You're right, the Irish Congress of Trade Unions have requested from the previous Minister, Minister Humphreys, that Regulation 224 would be amended to include the definition of personal injury, to amend it to include an occupational infection of this kind. We have also written separately on behalf of our members, and there is, as I understand it, a meeting scheduled for this week with the Irish Congress of Trade Unions and the current Minister, who's Minister Varadkar, and the Taoiseach, to deal with that issue, because to date the response has not confirmed that that regulation will be amended, and that's what's needed. We also know that in the European Parliament that the definition and the biohazard directive now includes as category 3 the COVID-19 as an occupationally acquired injury, particularly as it is. And as my colleague Siobhan will be able to tell you, when you work on these wards and you work for 12-hour shifts, you know all about it when you become infected. And the long-term effect of this is quite severe. And Siobhan has now just entered her 12th week of being absent from work due to the after effects of being infected, which simply cannot be described in any other way except that was an occupationally acquired illness.
Right, thank you very much. I also just want to note the point that you made in relation to the staffing levels. And obviously COVID has exposed huge failures right across our public services, but nowhere more than in the health service. And the point that you make about being understaffed significantly as a result of large numbers of staff out sick, and the need to ensure that there's a funded workforce plan. So we'll very much take that on board as a committee. I just have, in the couple of minutes left to me, I just have a question then for SIPTU and for FORSA. Again, in relation to the absence of protections for so many of our workers, and the fact that, there's a very large number of healthcare support staff who are in very precarious, low-paid jobs, and this being a factor in healthcare assistants, for example, continuing to go to work when they had the virus because of the lack of statutory entitlement to sick pay. What kind of percentage of your staff in the areas that you represent do you believe are in that category of precarious workers who don't have the statutory entitlements that many of the rest of us take for granted? Maybe to SIPTU first.
Okay, I can be very brief, Deputy Shorthall, and thank you for the question. The reality is that for the healthcare workers and healthcare assistants who are employed directly by the HSE, they would have a sick pay scheme, and they would receive sick pay benefits from that. That would not be the case in the private sector, particularly the private nursing home sector, where they would not have any kind of advanced or reasonable collectively bargained pay terms and conditions of employment. That would include sick pay schemes. And it would equally be the case in the contract services, not delivering direct healthcare, but doing essential work to ensure healthcare can be delivered safely. You're talking there security, cleaning, private contractors and so on, who in the main, the vast majority of them do not have sick pay schemes. So within those kind of categories, you are talking very, very high percentages that don't have sick pay schemes.
If we could,
maybe?
very briefly, because we're well over time. Thank you.
Yeah, just we'd have a similar experience in Section 39, voluntary agencies representing workers without those type of protections. Within the HSE structure, we wouldn't have experience of that in Forsa. But just to point out that it's no new thing for healthcare workers to go in when they're sick. I mean, during non-COVID times, because they're healthcare workers and they get to work when they have bad colds, and that's normal. Because, but what I'd say is that on this occasion, we were at great pains to point out to people that some of the choices you make to go into work when you have other symptoms that you don't present on this occasion. And we were at great pains to point that out within the context of the public guidance.
Thank you.
Okay. I just think it's
sorry,
all
we're
the more
2 minutes over time, Deputy.
Yeah, it's all the more regrettable that, you know, when we debated these issues last Wednesday in the Dáil, that the motion to put a focus on the vulnerable nature of workers in the health sector in particular was voted down. Thank you.
Deputy Boyd Barrett, 5 minutes. Thank you.
Thanks. First of all, can I thank all the contributors, and can I particularly pay tribute to Siobhan and all her colleagues for putting themselves in harm's way in clearly very, very difficult circumstances to protect all of us over recent months. But it seems from what you're telling us that the rhetoric that we heard about the wonderful work of healthcare workers hasn't actually been matched by really supporting the frontline healthcare workers, such as yourself, in the way that they should. And I mean, I have to say that listening to your contributions, I just find it shocking and frightening what you're telling us, that it is shocking and frightening that what you seem to be saying is healthcare workers on the front line are working unsafe hours with unsafe staffing levels, being put under pressure to go to work even when they have underlying conditions or for financial reasons, and that if that persists, we are in deep trouble if there's a second wave, as is very likely in September and in the autumn. I mean, is that a fair assessment of what you're telling us? And I'd really like to hear from Siobhan on this. I mean, do you feel that the lessons are being learned about what happened to you and the experience you've gone through? And are you prepared, are your colleagues prepared, and most importantly, are the HSE giving you the support to be prepared for what's coming in the autumn?
Thank you. Firstly, I'd like to point out that I am 27 years of age with no medical previous or underlying health conditions. I unjustifiably contracted COVID-19 in the workplace, as was previously said, due to understaffing, being completely overwhelmed with the role of the nurse, extreme burnout as well, and overexposure to COVID-19. I believe I was competent in my PPE. We had extensive training and education on the ward from infection prevention and control in the hospital on a daily basis, as PPE did change depending on supply. In terms of being prepared for a second surge, as nurses who are professionals who, I'm speaking from my own hospital, I can't say any of my colleagues presented to the ward with symptoms of COVID-19. There's a very clear pathway that you isolated, you got a swab through occupational health in work and you got your results and subsequently were off work for 14 days, if not longer, as in my case for 12 weeks due to symptoms. Going forward, the psychological impact of COVID-19 has been detrimental to myself and my colleagues, and I'm sure I can speak on behalf of the Nurses of Ireland when I say that. Being given a phone number or an app to access from home for psychological trauma, for PTSD, as was mentioned, just is not sufficient. We need significant debriefing going forward. Our mortality rate was incredibly high. We're nurses to save lives, but we were fighting a losing battle at the very start of COVID-19, and we don't want to see that again. Personally, I don't think I can walk into a workplace that is unsafe, and that is how I felt at times, even though provided with PPE and I was competent, as I said. To me, the workplace was a hazard. I ended up in hospital for a week due to my symptoms that escalated out of my control, and I had to be monitored and investigated as an inpatient in the hospital where I work, where just a week previous I would have been standing as a nurse at the bedside providing care to dying patients who succumbed to COVID-19. That's extremely traumatising, and I don't know if any nurse could overcome that with just a number or an app. More needs to be done.
Yeah, and just Siobhan, I mean, and just thank you so much on behalf of all of us for what you've done. What do you feel that there has been lessons learned by the HSE, by the government, from the experience that you've gone through, the rather harrowing experience you've clearly gone through? And do you get any sense that the problems are going to be addressed? I mean, what would making the situation different and better for you mean on the ground as a front care health care worker in the autumn? Is it about just more staff, working less hours, less periods of exposure, and more, support for the psychological impacts? If I could ask you that, and maybe just quickly, because my time is out, for Phil. Phil, I mean, just very briefly, what numbers, Phil, do we need to get to recruit into the front line to be at safe levels to deal with COVID and non-COVID healthcare come the autumn?
I'll just keep it very brief. We definitely need increased numbers in staff nurses permanently, not just agency staff that come in and, for a day here or there. We need to increase the number of nurses that are on a roster. We work 7 days a week, 24 hours a day, 365 days a year, and if somebody falls sick, they have to be replaced. I'll pass you over to Phil. I don't have any time.
Thank you, Deputy. I think the figures we constantly quote are the figures that were in place pre the first recession, and we're still working with 1,000 fewer nurses today than we were in 2007. And we know the health service is much busier. In providing both COVID and non-COVID services, we need a minimum of 5,000 more nurses, a minimum.
Thank you.
And that includes midwives. It's nurses and midwives for both services.
Right over time. I'm sorry to cut across you. If I could just say to Siobhan, thank you for outlining that post-traumatic stress disorder is a very serious clinical psychiatric condition and requires appropriate and urgent supports to try and help people through what can escalate and become a very difficult condition, and appropriate diagnosis at the earliest stage. And thank you for outlining, an experience so far. But it is important that, it is also a phrase that is used too easily when it is a very specific clinical psychiatric diagnosis. And so for those people that are at risk of having acquired it through trauma or for it developing for the future, it's very important that they get the correct diagnosis and treatment at the earliest stage so that it does not escalate. Thank you for highlighting that. If I could move on now to Deputy Shanahan, please. You have 5 minutes.
Thank you, Chair. And thank you to all our witnesses today, and particularly Siobhan again. Thanks on behalf of all frontline nurses. You've done an incredible job. I said in this committee on Friday that I thought over the course of the day a level of exasperation was quite evident. It's been evident in this committee for a while. It's evident here today. I think anybody listening to the evidence, anybody reading the submissions couldn't but be exasperated. And I think we can all accept there was a level of unpreparedness, obviously, because nobody knew what was around the corner. What I'm concerned with now is what have we learned and what are we implementing before the winter comes in. I have some background in infection control. You said that masks were asked for on the 22nd of April. I actually asked for them to be mandated in the Dáil on the 4th of April. So there were things that we could have been doing. In terms of PPE, and someone said here that hand sanitizer isn't available or is only available through, one supplier. Most of the distilleries in the country have been providing hand sanitizer alcohol available to healthcare, so there should be absolutely no reason that we do not have hand sanitizer. And I would encourage the unions here today to get with the procurement in the HSE and to talk about these things. PPE, I've worked with a number of companies domestically in Ireland who are trying to supply PPE into the supply network with great difficulty because of government procurement. These are things that must be addressed. I can tell you I've sat in hospital waiting areas and I've looked at staff migrating through hospitals with their swabs on down into the community areas and back up to the wards. That must come to a stop, as must allowing the public transit through all areas of the hospital. These are infection control procedures that need to be put in place, and they are the very first and frontline policies, I believe, that you need to be speaking to the Minister about very robustly. Could I just ask Phil, one of the things I mentioned here before, temperature testing. Has the INMO any opinion on whether staff should be temperature tested the same as they are coming into industry in the morning time before they start work, if you please?
Thank you, Deputy. Temperature testing has a place, there's no doubt, but we're more worried about the asymptomatic presentations, that is, people who present with no symptoms but are infectious. And we also have, for example, a policy that we're seeking jointly with all of the health sector unions to we have asked the HSE to change their policy of derogating staff who are a close contact but have no symptoms to come back to work. We simply believe that's just unsafe. We need swabbing. We need to know the status of workers. In the private sector, there now is mandatory swabbing, but in the public acute hospital system, there is not a policy of swabbing staff as a mandatory. And the HSE will be talking to you later, and they'll say that, as they have said to us, that a swab is a picture in time. We believe it is necessary because we know that asymptomatic workers in the private sector are being picked up as positive. And when they're asymptomatic and positive, they still pass the virus on to somebody else. So therefore, the most important thing, temperature is one symptom, and a temperature can have a number of different reasons, but the swabbing of frontline workers must be mandatory in the acute service as well as the private sector.
I'd agree with you wholeheartedly on that. And can I say I also brought up previously in this committee about donning and doffing, and I was told that HSE had provided videos. I was contacted by a nurse up in Cavan Hospital many weeks ago who highlighted the issue of donning and doffing of protective clothing, and guess what? 2 weeks later we had one of the highest spikes in healthcare for that very reason. Again, I would ask you to speak to the HSE. These are simple things to be implemented, and I think the very first thing is workers need to be protected. Everybody accepts that. We can't protect from everything, but we can mitigate as far as possible. I also think you should be talking about more flexible rotas to the HSE. Maybe there's a sense that nurses should only do 4 hours on, 4 hours off, and some kind of alternate shift change to reduce the level of fatigue and thereby reduce the level of infection. But I applaud everything that you're doing. I feel really sorry for frontline workers who have been caught up in this, and I also feel really sorry that we are not learning from the mistakes of the past, and I hope you will bring that very forcibly to the Minister, which I certainly intend to do also. Thank you. Thanks, Chair.
Are you Deputy Collins? 5 minutes. Please.
Okay, thank you. Thanks, Chairperson, and thank you to our contributors here today. Maybe I might address these questions to Phil at the moment. How early was testing of residents and staff carried out in care of elderly facilities, and should it have commenced earlier? And did the failure to carry it out early lead to staff and residents being at higher risk?
Good morning, Deputy, and thank you for the question. The swabbing of staff in the private sector followed the presentation. So if there were presentations and symptomatic presentations, then swabbing followed. In the public sector, in care of the older person services, it depended very much on the availability of the swabbing facility. But for example, in Cherry Orchard Hospital, they have a lab on site, and they did swab their staff who presented with symptoms, and they had a very good experience of COVID, if you could call it a good experience. In other words, the infection rate was quite low, and the transfer of that infection to other staff was kept at a minimum, and they enforced the policy of self-isolation for 14 days quite strictly. And even though the HSE's policy was close contacts could be derogated to return to work, they decided and they took decisions that they would not implement that. And I know that because I spoke to one of the assistant directors there who felt that that was really important, that they should not derogate staff to come back when they did not know their status and they hadn't been swabbed. So that policy, we have requested that that policy be removed, that staff, if you are a close contact, no more than a member of the public, if you're a close contact today, you'll be advised to stay at home and to self-isolate for 14 days. That should be no different for health service workers.
Okay, and thank you. In community hospitals, we have situations still that the HQ standards of single bed occupancy hasn't been met. And where there's multi-occupancy rooms, did it lead to the spread of Covid-19?
Again, I think our members will say that one of the lessons learned is that the isolation of patients who are whose status is unknown certainly should have been dealt with earlier. Very difficult to do if you're awaiting swabs and the results take a long time to return. That's improved, but we certainly have a huge problem of the availability of isolation facilities, both in the acute and long-term care, undoubtedly. We need more isolation facilities. And in our EDs, for example, we know from our figures that we count on a daily basis. We have overcrowding at the moment. We have overcrowding and we don't know the status of a lot of the patients when the areas are overcrowded. And that is a recipe for disaster.
Yeah. And I understand that Ireland has the highest COVID infection rate for health workers in the world, and that 1 in every 10 COVID cases reported are healthcare workers. Given that over €1 billion will be spent on personal protective equipment in Ireland this year, how is it possible that healthcare workers did not have access to adequate supplies of PPE?
Again, the best evidence of that, I think, is from Siobhan, who was in that situation, was fully protected with PPE, but still got infected, as did 12 of her colleagues. So it isn't just about availability. Availability was a problem, and a real problem at the beginning. That improved, and it largely improved because of the work of the trade unions in this room, because we sought that face masks should be mandatory for all healthcare workers. That's the point. The point is there are other reasons, and the agency that should be examining what those other reasons are is the Health and Safety Authority. And you as committee can recommend that they now get on this pitch. We've been asking for it. The Irish Congress of Trade Unions are asking for it. The workforce are saying this is really serious. This is a hugely infectious pandemic, and the agency that is entrusted with workers' welfare, ensuring that workers are safe when they go to work, isn't on the pitch. That's simply not fair.
Just a comment on that. During the spike in April, when almost 6,000 cases among health workers came, the numbers that were caused by deficits in PPE were surprisingly low. That most of the transmissions were through the workplace, in the work setting, as Phil says, in a very risky environment. And we were talking about swabbing a few minutes ago. A number of our people who wouldn't be considered as frontline workers, who stepped into the front line to do swabbing, got infected. So, you know, it's a highly contagious environment, but the numbers of infections caused by inadequate or lack of PPE were surprisingly low in that April period. There was a huge problem at the outset, and as Phil said, the trade unions moved very assertively to try and correct that. But it's the totality of the work environment that needs to be observed. I wouldn't like anybody to think that if we book up on our PPE arrangements, this will be okay, because it won't. There's a number of factors.
Deputy Collins.
Okay, is my time up? Yeah.
Deputy McAuliffe, 10 minutes.
Thank you, Chair. It was interesting. A number of the questions which I had identified have already been asked, and so I won't ask the witnesses to give them again. But it's interesting looking back at some of the contributions and the words that were used by Siobhan when she used the phrase catapulted, when Michelle spoke about what the context was like, what COVID was like. And I think looking back on some of the time that happened, obviously there are things we couldn't have changed given the speed which came on us, but I think it's exceptionally important that we learn those lessons now, so that any future change in the COVID rate is protected. And I think particularly on masks, we're all sitting here wearing masks today. Not just Ireland, but the entire world got it wrong on masks, and we have to make sure that we don't make that same type of mistake in other areas. So I just want to thank all the workers. I'm on the record as saying that we need to make sure that it's more than just thanks, and I've no doubt, Ms Nihay, you and your colleagues, when you meet with the Minister today, you'll be very forceful in terms of the obligation the state has to the workers who have protected us. On that, I'd like to turn to the vaccination for influenza. And I've said now for some time that I'm quite concerned that we are going to have influenza and COVID at the same time, and it's going to lead both to economic difficulties because there'll be isolation where that's not needed, but equally that's an increased risk for patients and for healthcare workers. Can the witnesses talk about the availability of influenza vaccination at this moment for healthcare workers?
Where I work in Connolly Hospital, you're almost mugged to get it, because there's people on every corridor offering it to you and asking you why. So it is very readily available in the acute sector for all healthcare workers. The private sector I will leave over to Ms Nihay, so I'm not sure, but certainly in the acute public health sector, we're hugely encouraged to take up the flu vaccine.
If I may, Michelle, just to complement that, because it was only on a phone call with the HSE last week that we were informed that while the word mandatory might be a little bit over-assertive, but that there will be a new vaccination which actually has 4 dimensions to it rather than the usual 3, which every healthcare worker will be, I suppose, in inverted commas, expected to avail of. So that is encouraging, and the trade unions have their part to play there too. But I wonder about the City West facility and the decision to stand that down when there were 300 beds that we went out and had a look at it. And it was a phenomenal piece of work. The construction of that City West facility, it showed everybody what could be done. And okay, when the numbers were reduced in terms of the COVID, surely it would have been a way of anticipating a flu surge, for example, from the autumn onwards. I thought that was a strange decision.
Given the availability of the flu vaccine, both for healthcare workers and then I understand target groups, I think there's 1.9 million vaccines that we have identified. The HSE don't seem to be progressing a population-wide programme where the objective is that everyone in the population would have that same level of access that healthcare workers have. And that will have an impact in those people presenting to emergency wards, and that will put pressure on healthcare workers. And I wonder if the unions haven't given any thought to the impact of that on the already depleted levels of staff.
Deputy, the numbers from last year's flu epidemic indicated that the pressure on ICU beds was significant. So we know that those that get very sick with COVID-19 require intensive care beds, and that we don't have a surplus in this country. So that again indicates that the private hospital facilities must remain available to the public health service. Undoubtedly the intensive care units and the beds, because they're already staffed and they have ventilators, they must be available. The flu epidemic has been a feature of every winter. Our hospitals have been overcrowded, extraordinarily overcrowded, right into February. That's there's no indication that that'll be any different this year. But what will be different is that we'll also have COVID. So we will have to redouble our efforts to make sure we have the capacity and the staff. And the trade unions and our union has agreed that our members over the past 2 winters have now engaged in a peer vaccination programme. That's a policy of the HSE. In other words, if I work in Hospital A or Hospital B in the public or private sector, that if you are a nurse, you can vaccinate. Therefore, that is now in place. So our members do that. They vaccinate their colleagues in order to ensure the greatest uptake of the vaccine when it's available.
Thank you, Chair.
Finished? You have more time if you wish.
No, that's fine.
Okay. Deputy Riley.
Thanks very much, and thanks to our witnesses, and thank you to those, particularly those who have appeared before us and who have been so generous with their time. Can I ask, the SIP2 submission refers to, it says, there's no doubt the experience of the pandemic has taught us many lessons. These experiences must form part of our planning for the future. In many cases, services were unprepared and did not have the essential equipment or training to support and protect healthcare workers in the fight against COVID-19. So my question, it's to everybody, was on the basis of that assertion. How much better prepared are we going to be if we face, and we all hope we don't, but in the event that there is a second wave, are we going to be much better prepared? Have we got the requisite number of staff in place? And will the equipment that is going to be necessary be available? And I say this in the context, and Ms Hay has referenced it there, to the flu. And I'm on the record as having said we have a succession of health ministers in this state, all of whom seem to be surprised every year by the flu when it happens at the exact same time. But in the context of the potential for an increase in hospital attendances because of the flu, the reduced number of beds that are going to be available because of physical distancing, is there additional capacity in the system now to take up that slack?
Yeah, I'll take that question first, Chair, and I thank Deputy O'Reilly for it, because really what the intent of our submission and contribution today is really to challenge, I suppose, the policy people and indeed yourselves as legislators in terms of ensuring that we are at that state of readiness. I think some of the experiences that we've had and continue to have do leave a number of unanswered questions, and that we do need to make sure that we don't repeat the mistakes. Like, the one thing we don't need to do now is to wait for it to arrive to get ready for it. We know it's here, and that there is the real likelihood of a second wave. I mean, we have touched on the issue of the staffing resources. And the fact of the matter is that there's not enough staff in any grade, and I think there are real issues there, and particularly in the context of dual pathways and issues around equipment and so on, and you know, COVID and non-COVID patients arriving into those kinds of situations.
There for a moment. Apologies, John. Have you been involved? Have the trade unions been involved in planning for a second wave? And in that regard, have you had sight of the additional capacity we all know is needed, but have you had sight of the additional capacity that the HSE have sourced, or have they sourced additional capacity? What has been the level of engagement in terms of preparation?
Well, I don't have sight of it, Deputy O'Reilly, and I'm not sure that the level of engagement, even in relation to the contributions that were made by our colleague Phil, in relation to the funded workforce plan, the HSE have been consistently behind dealing with that issue. So the issues in relation to staffing, the issue in relation to having the people and the equipment to meet the challenge that is going to come is something that is of deep concern. I mean, the trade unions do engage on a weekly basis with the HSE at a senior level, and many of these issues are discussed. I suppose the real challenge is to ensure that the correct policy decisions are taken so as to enable those discussions deliver meaningful outcomes.
If I may just comment, Deputy O'Reilly, because I've been involved directly in the discussions that John has referred to. No, we have not had sight of any plan for a second wave, is the explicit answer. And one of the reasons for that is what I explained earlier, is that when the national emergency struck, there was a command and control model and a mobilisation of the workforce to do something we'd never done before. But if there's a second wave, it comes in different circumstances. It comes in circumstances where, on the positive side, we are better equipped from the point of view of tracing. We are better equipped from the point of view of identifying contacts. We know more about the illness. So that's a positive. On the negative side, we've handed back 300 beds. We don't have a workforce plan. We haven't seen sight of it. And if people think that a new command and control model that will have the same effect will be possible, it simply won't. Because here will be the difference. The difference will be that there have been cancer diagnostics which were delayed for a number of months. There have been therapy interventions for people who are vulnerable that have been delayed for a number of months. There have been all sorts of stuff. Disability services closed down for a number of months, and the system won't absorb that. So you go into a second wave having to keep these other things open. And how the HSE ask of the Be On Call Ireland could only have been 125 people is beyond me. It's absolutely beyond me. It's staggering. And what I'm saying to you is it will not be possible to do the job and keep the health services alive with 125 extra people. And if the civil and public service model and the Be On Call Ireland is what it is, well, then they need to go to the area of need. And the HSE needs to get on top of that. So that's how we prepare. But I think it's high time that that was tabled for discussion, and not in a command and control manner, that we should expect the second wave, and we should expect to be able to deal with the second wave living alongside the rest of the health services.
And Deputy O'Reilly, if I might just come in, there's two elements that, to my mind, seem to be ignored in all of this, and it's the other front line that people forget about, and it's the front line in the community where our home health coordinators are represented by Forsa, and then SIP2 would represent the home health workers who go into the home. They were the unsung heroes of the pandemic, and they kept so many people out of the acutes, and part of any conversation about dealing with the second wave has to include that element of the health service. And just the other point I wanted to draw people's attention to is the structural deficit that is within the wider health service, that we have the HSE hospitals, the voluntary hospitals, the Section 39s providing disability services, and the Section 38s. And again, if we've to approach the second wave, as my colleagues have said, with a bit of time now to plan it properly, we need to look at all those factors, because we call on the HSE to do things, which is very important, but my colleagues who are involved with these weekly meetings with the HSE know that we also need the voluntary hospitals to get on board with that, as they are all independent bodies. So it's just two elements that we need to keep in mind.
There needs to be a whole system approach, Catherine, you're dead right. Ms Mihey, have you any observations on that?
Yes, thank you, Deputy. I think the important point is the additional beds are needed, and they're needed very quickly. We know, for example, we're currently involved with a care of the older person services that has gone into liquidation. I don't think that'll be unique. I think that will be quite regular, unfortunately. The HSE in its service plan in last year sought to remove 200 beds from care of the older person service. We wrote to them objecting, we wrote to the Minister objecting at the time. We need to increase the public service capability to provide care for our older persons, and we know that that has to be a priority, because we know that this virus directly and has a much greater effect on that population, and we also know that our population is ageing. We also know that the flu takes a particular toll on our elderly population. So for those reasons, we need to be increasing our care of the older person service beds. We also need to look at our ICU capacity, as I've said, and also the 3-month contracts that were issued to staff to work in the health service during the pandemic. There's a constant requirement to repeat and seek approval for a renewal of that contract. Two things. Yes, one, it should be directly hired, and if there is any mention of a moratorium in the health service again, I think we would ask all deputies listening to what has been presented today to oppose it.
And I think there will be very strong opposition, certainly from the opposition benches, if there's any suggestion of a recruitment moratorium. I don't think that's acceptable. Siobhan, I was struck by what you said in your opening statement in relation to how staff and how you in particular are feeling overburdened, burnt out and overwhelmed. And those are very, very serious words. I sincerely hope that the powers that be in the Department of Health and in the HSE listen to those words and take them on board, because if we are to face into a second wave, I think there has to be some acknowledgement of the residual impact of what we've all just been through, but what our frontline staff in particular have especially been through. So just with regard to, and I'm not asking you to comment on your own personal situation, if you could just outline the residual impact in terms of annual leave, in terms of any annual leave that you might have left or any that you might have used or your colleagues might have used to take care of kids, and what the impact of that is going to be as we head into a second wave. And I would also just like to take this opportunity to thank you and to thank Michelle and all of the other frontline workers, because they did a job for us that was near impossible, but you did it anyway, so thank you.
Thank you. So personally, I've been off on basic pay sick leave. It's counted as COVID sick leave, so it's not taken out of my own sick leave requirements for the year, but I am on basic pay, so I'm losing out on night pay, weekends, bank holidays. We've had multiple bank holidays. My colleagues who have children had to take annual leave just to look after their kids at home. That's basic pay as well. It's not a choice, I suppose. Being sick and being off, I'm not going to walk into the workplace until I'm near enough to 100% better, and I've been told that could be October if not November, given what I've been through personally. And again, I know the childcare issue is ongoing. I don't have kids myself, but my colleagues do, and that is a concern, because that's more staff that aren't on the floor because of lack of childcare facilities, and again their pay is affected as well.
Thank you. Thank you very much. Thank you, Deputy Riley. And Deputy Durkin, you have up to 10 minutes.
Thank you, Chair. Like others, I want to compliment our witnesses for being here today and for giving us the replies that they have given, and also for the tremendous work that they have done throughout the COVID crisis. In relation to staffing levels, which has always been a sensitive issue, can I ask, maybe Phil might elaborate on this, as to whether or not, when increases in staffing levels throughout the HSE took place, were you satisfied that proportionately the nursing staff levels were increased proportionately? Or did you feel that there were less nurses appointed than to other aspects of the service? That's the one question. And maybe I might go with that answer first, if possible.
Thank you, Deputy. I think the number of staff nurses that increased, staff nurses, the frontline grade, has been quite modest, 230 in the last year. We are reliant very heavily on our student population, and we saw that during the pandemic, where our unqualified students were redeployed and worked as healthcare assistants, and also the fourth years worked on the wards. And again, great thanks is due to them to do that. I don't think it's a competition. I think the health service is short of all staff, of all grades, but most particularly those that work on the front line. And most certainly we're not satisfied that the proper measurement of the shortage is being utilised. So, for example, the care of the older person services, their staffing levels are determined by a cost of care. So in other words, what can we afford, not what is the best outcome for patients. We have two scientific policies now, thankfully, that have been adopted by government as government policy that determine scientifically what staffing you need, what ratio you need, what mix you need. And as I said earlier, in the acute hospital sector, that's 80% nursing to 20% healthcare assistant in an acute hospital, and that demonstrates that the patient has better outcomes as a result of being staffed like that. We're nowhere near that. And also, what the research into that scientific piece of work found was that it actually saves money, because you increase attendance, you cut down on burnout, and you reduce the length of stay of patients because their outcomes are better, because the care gets to them quicker. So we know what the answers are. We have the policies. What we need now is to ensure that the Department of Health, the HSE, and the Department of Public Expenditure and Reform back it up, and that they fund the workforce plans. They have to fund the workforce plans based on the science, not based on availability of resources. Because when you base it on availability of resources, you're saying to the frontline workers, we can only afford X number of you and get on with it. And we don't accept that. We've never accepted it.
Yeah. Essentially, though, my question was, to what extent were you reassured by the increased strength of nursing staff, general nursing staff, in the period during which a considerable increase took place in health staff throughout the country? So were you disappointed at the degree to which nursing staff increased, or were you pleased that proportionately staffing levels in the nursing sector were adequately replenished?
First and foremost, I don't believe that they were increased. We're working with 1,000 fewer than we had in 2007, so they haven't increased. And we also know, for example, in the staff nurse grade, that since last December, that the increase, if you want to call it an increase, was 238. Now, that's not. We're still not at the 39,000 we had in 2007. Yeah, and we are, as I said, reliant more and more on the unqualified student to provide services when we know they shouldn't be.
My question was and is, out of the total number of staff, new staff appointed before the moratorium, out of that, the nursing levels were increased by a proportion. And the question is this: was that sufficient, or was it lower than that applied? We believe that it was, but we haven't seen the information to back that up.
Well, the HSE Stats Deputy set it out, so the premise that they were increased is incorrect. They weren't increased. We're still working with fewer nurses and midwives than we had in 2007. So they haven't been increased.
Yeah. I have to say that's not true, of course, because there was an increase. Deputy Burke has already outlined the total number of staff, extra staff employed by the health services. And this is not a criticism of anybody. It is simply an effort to ascertain to what extent were the staffing levels at nursing level increased, and was that in proportion to the general increase of 20,000 or whatever it was?
Well, again, Deputy, without labouring the point, I have the figures here. So the numbers in January of this year, total numbers in the health service whole-time equivalent was 119,817. Now, if you look, depends on when you're measuring from. We're measuring from when we had 39,000 nurses, and we know, for example, in the nursing category, that the numbers that differed between January 19 and January 2020, 125.
It would appear
125.
It would appear,
and that still provides for a total number of nursing staff, which is 38,205, when we had 39,000 in December 2007. So we haven't increased.
Messing with 2007 is not what I was asking for, because...
So if you're asking what's the proportionate increase, consultants increased during that period by 172, registrars increased by 183, and these are the HSE's figures, these are on the record. We know that our figures, the numbers, the biggest increase in the nursing numbers were in the student nurse category. And there was decreases in other categories. So we know, for example, in the clerical and administrative grades, which my colleagues here represent, the increase was 276, and in the higher management grades, it was 309 for the same period that's reported upon. So, from a nursing point of view, of course, we think that 100 and in the staff nurse category, that 125 doesn't come near. That doesn't even replace those that are on maternity leave. Those that are on maternity leave, for example, make up 3% of the entire workforce, because 95% of nurses are women. And we know we do not have enough replacements for maternity leave currently. We know this. So what happens when a nurse is on maternity leave? The remainder work short.
Ms Nihay, you may not be able to see Deputy Durkin is trying to come back in. I may let him in, please.
Yes. Have I much time?
Yes, 2.5 minutes.
That's okay. Can I ask in SIP2 in relation to the concerns expressed whereby staffing in various situations throughout the country were reluctant to report with symptoms on the basis that they might be disadvantaged or that they might have competing needs and were reluctant to come forward. Have you documented evidence to that effect, and if so, how widespread was that?
Deputy Durkin, we don't have documented evidence. What we did say to the HSE and to the Department and the Public and Expenditure and Reform, that when they introduced that particular policy, we felt that it was wrong, and we felt that it could act as a disincentive. What I would say is that the context when that particular policy was introduced and what was happening in the health service executive does not reflect what it is today in terms of the testing capability in particular and so on, and the ease with which people were being sent home and in many cases being left at home for up to 2 weeks without being tested if they showed any kind of symptom at all. And of all of those people who were sent home, 97% or thereabouts were shown not to have any symptoms, and in those circumstances people were financially penalised. Now, the point of putting it into the submission whilst telling that particular story is not really to labour too much on that particular point, but it's to say that policies such as that serve to act as a disincentive in circumstances where you're dealing with an issue like COVID-19 can be counterproductive. And therefore what we would be saying is that such policies should not be in place.
Thank you.
Thank you. I'm struggling with that. It would occur to me that it seemed to be better to be sent home if you were displaying, if there was a concern in relation to it. If you're, this session has been about concern for infection of healthcare workers, but I'll pass over to Deputy O'Dowd.
Fáiltíim rithna daoine an seo agus tuigeann go bhfuil job an bhá déanta ag daoine bhí na gobars na health service an town Galéir. There's one question I have about the flu vaccine. In preparation for a future, obviously it's going to come anyway, but the possibility of the flu and the return of COVID-19, do your organisations have a policy in relation to mandatory flu vaccination of all healthcare staff?
Deputy, from the INMO's perspective, we have a policy of promoting the uptake of the vaccine. We have a very clear policy on that. The Minister for Health, the previous Minister for Health, Minister Harris, sought some legal advice, I understand, on the status of mandatory, and we are awaiting the publication of that because we haven't seen it. But my understanding is there is some difficulty with the introduction of mandatory vaccinations, and that legal advice that was obtained by Minister Harris set that out. So we haven't seen it, as I say, but we do have a very strong policy of promoting the uptake of flu vaccination. As I said earlier, not only that, we also have agreed with the HSE a programme of peer vaccination, which sees our members providing vaccinations to their colleagues in their workplace to ensure that the uptake is increased. And that has proven, and Dr. Kevin Kelleher has confirmed to us that improved the uptake significantly last year.
So what was the uptake last year?
Just over 37% in the grades of nursing and midwifery, and
quite low, isn't it? Like in terms of, I appreciate the point you make, and I understand the legality of mandatory in terms of legally challengeable orders, and I welcome your commitment, obviously, for everybody to accept it or to get vaccinated.
Promotion, yeah.
I think we need to do more, all of us, to make sure that everybody who works in a health environment, and where obviously, particularly if you're vulnerable people, and anybody who's in hospital obviously is vulnerable in one context or another, that it should be 100%. And just how can you accelerate that, notwithstanding the legal issue that you raise? And I accept that that's legal advice you're talking about, but the medical...
I think there's two things. One is that the stats we have, and the health service have accepted this, only reflect those that have been provided with the vaccine in the public sector. So we don't know if people go to their GP or get the vaccine elsewhere, because the figure, it is our view that the figure is much higher than that. And if we measure across the health care worker grades, public and private, it is higher. But I think the simple point is the flu vaccination is promoted. It's promoted strongly by the Irish Nurses and Midwives organisation. It is our policy to promote it. And we also have now agreed that our members would participate in ensuring that you don't have to travel, that you get the vaccine as close to your workplace as possible in order to promote the uptake. And that has proven positive.
The question I want to ask you, there's research published recently by the Edinburgh University in relation to the prevalence of Covid-19 in nursing home environments particularly, and they talk about the high footfall of staff, including agency workers, cooks and maintenance engineers, going in and out of the largest homes is thought to be a key factor for infecting elderly residents. So I appreciate that you represent the nursing profession as such, but in terms of agency nurses, is there any analysis done of all the people who have been infected, what proportion are agency nurses as such, or do you know that, or is it an important point to make or to try and follow up?
There's a number of questions, Deputy, that we've sought answers to from the HSE. That's one of them. We know, for example, that the stats that are produced by the HPSC on a weekly basis, and that's only happened in the last month because we've sought them, they do not demark the numbers beyond the categories, the broad category of nurse, for example, healthcare assistant, doctor, porter, other healthcare workers, and unknown. So we have asked for information to allow us determine where the areas of most risk are. But we know now, for example, that 34% of all of the infections are among the nursing grades. We've asked for a breakdown of public and private, and we've asked for a breakdown of those that are fully equipped with PPE, such as Siobhan here, who worked on a ward with 19 others, all wearing PPE, all protected, and 12 of them contracted COVID-19.
Right. I understand that point, and that's why this research it's the first, I think, academic research which is concentrating on the issue. What they're saying here is that the larger the care home, now I'm talking about care homes, I'm not talking about obviously acute hospitals as such, you're 20 times more likely to get it than a smaller care home. So the question I have for you, it's a question that concerns me a lot. It's the regulations for care homes and qualified or professional nurses. There's no relationship between the number of dependent or high dependent residents and the need for professionally qualified nursing staff. And I think that's a huge concern to me. And I think it is unacceptable that there wouldn't be an appropriate and proportionate relationship between high dependency and qualified nursing staff, and indeed other qualified persons as well. Do you have a view on that?
Deputy, we have a very strong view on it, and we've made a number of submissions to government in respect of it. We need dependency level staffing. We need staffing based on the scientific evidence that determines what is the best outcome for the patient. We have a cost of care model in Ireland. We absolutely reject it, and we also have a real problem with the staffing levels in the private sector, where pay rates and collective bargaining for trade unions is not facilitated. So we are currently dealing with a lot of our members who work in the private sector who have huge differences in terms and conditions of employment to the public sector, but also who are trying and struggling to provide the service that's needed because there aren't enough of them. It's not unusual to have one nurse for 30 patients. You saw the evidence of that during the whole pandemic, and the ability to provide correct and safe staffing levels in the private sector does not exist at the moment, and that is unfortunate. And HICWA, we have called on HICWA to make commentary on staffing levels on numerous occasions, and right now what we need is a government policy that confirms that staffing levels in the acute sector, in the care of the older person service, public and private, needs to be based on dependency levels of the patient, and there is a tool, and it is government policy, and the government have stated that they will fund it, but we haven't seen any evidence of that. So the funded workforce plan is required, and we need to have engagement both with the Department of Health, with the Department of Public Expenditure and Reform, and you're right, because it needs to be based on science.
A part of the problem, and I appreciate I'm still in time, am I? Yeah. There's one of the problems, and I have a relative or an in-law who's in a nursing home, and he's been extremely well looked after, and there's a very, there's a very good mix of people working there, and I want to say that. But I think the problem is that when somebody's selecting a nursing home, they really are looking for somewhere near where they live. They don't really know anything else. They go in, they sign the contract of care, but there's no mandatory requirement on the nursing home, be it public or private, to say, you know, what are the staff levels, what are the other auxiliary, like many people need speech therapy, physiotherapy, all sorts of other things. But what you do find is you'll always find, you know, a tenner a week or 20 euros a week for something that many people can't avail of or use. People with dementia, 70% of our people in nursing homes have dementia. So there's a huge lack of transparency about the 60,000 euros people are paying, certainly at least 60,000 for the care that they're getting. And people say that the billing is fine and they often look really lovely, but there's no real, you know, the quality of care varies very significantly. And I welcome your comments, and I think if I can suggest, if you haven't already done so, that may be part of our, Chairperson, or part of our report, if you have views on that issue that you may not have expressed, that we might put it in a recommendation if it isn't already, you know, before us. But I think until we get that certainty and that quality of care and that proportionality between qualified staff and medical and nursing need, you will not get, you will not get proper and adequate care in these institutions, in my view.
I wonder.
We agree wholeheartedly. I believe that the private for-profit model is the incorrect model for our older population. We've made submissions to this committee and to the Health Service Committee, the Direct Health Service Committee on this matter. There's absolutely no doubt that the 200 beds that were earmarked to be taken out of the public sector last December in the service plan, we raised that right across the political spectrum with the HSE, with the Department of Health, and the model in this country is to privatise care of the older person. That's the wrong model. The model has to be the state has to provide care for our older population and base it on the dependency level being the measure of how many nurses, how many healthcare assistants and how many other staff are required, not the for-profit and the cost of care model. It's incorrect.
Yeah, I just want to say, that I totally agree with you on what you're saying there, and I think that is the future for good, high-quality healthcare. Thank you, Gurmagat.
Thank you, Deputy O'Dowd. And just to say again, this committee is producing a report on COVID-19 in nursing homes, which will be circulated to members, and we'll be discussing it in a Teams meeting on Thursday. So if there is additional contributions that want to be made, now is absolutely the time in relation to that. Could I ask the witnesses just a couple of questions of my own, if you don't mind, please? Just going back to the question of flu and preventing people getting flu, because clearly the symptoms of flu and having flu, there's a contradiction in terms of being able to present to work and the risk to COVID-19. Could I just go back to the view of the witnesses on making the flu vaccine mandatory? I know we've talked about the view, Ms Nihey, of promoting it, and you have a figure of 37%, and you said you think that the real figure is higher than that. But can you outline what circumstances a healthcare worker would not wish to have the flu vaccine? Is there something that's preventing somebody from taking the flu vaccine? Is there something we're not aware of that would make it difficult to make that essential, if not mandatory, which has a different regulatory implication?
Well, I think the first thing, and thank you for the question, Deputy, the first issue is whether the healthcare worker, no more than any other member of society, has an underlying health condition that a flu vaccination would be contraindicated. That's the first one.
Could you give me an example of that? What underlying conditions?
Again, that would depend on the underlying health condition. From our perspective, we're very clear on this, that the healthcare workers that we represent, we promote the uptake of the vaccine.
Thank you, Ms Nihey. You did say that, and just being more specific in my question, if you don't mind, to help me with my own understanding. For example, could you name one or two conditions that are contraindications? Like, is diabetes, for example, a contraindication, or could you name one or two conditions where there's a contraindication with the flu vaccine?
My understanding is that it's allergy based, and it depends on your particular allergy, depending on the vaccine that is produced. As my colleague from Forces said earlier, the vaccine this year is slightly different to the vaccine last year. So that is a constant matter that you have to discuss with your GP. But the point is that my view is, and the view of the union, the representing nurses and midwives, is that healthcare workers and nurses and midwives are encouraged and promoted, and they go further than that because they also contribute to the uptake by ensuring that other healthcare workers can have the vaccine in their place of work, and we provide that to them.
Actually understand that and respect that, and I'm just trying to understand on an annual basis what list, how is that list of contraindications, how it's communicated, how clear it is, what those barriers would be, recognising I totally respect that there are some barriers for some people. Of course, the issue is that a healthcare worker who gets the flu will be deemed, I assume, to be of Covid-19 risk given the overlap of the symptoms, or a risk of having Covid-19 given the overlap of the symptoms. And what we've discussed today about the risk of infection from Covid-19 for healthcare workers, and what we've also discussed from Mr King about people staying home for different reasons or being required to self-isolate, there's a clear overlap. So what can we do additionally this year to try to ensure that people do get the vaccine and take the vaccine for flu that we have?
I think the HSE have done a good job in promoting the vaccine. I think we would encourage an escalation of that, do it earlier and do it more broadly. Educate people about the nature of the vaccine, the type of vaccine. There is a huge concern generally among the population. We hear it every year about vaccines in general. We don't subscribe to that. Our members who work as public health nurses are to the front line of providing childhood immunisations and also the meningococcal vaccinations. So we promote vaccines. We believe that the health service has to give correct information and contradict perhaps that information that's out there that is not based on science.
Well, I agree with you completely in relation to that, of course.
Sorry, Chair, just to avoid being repetitive if we can, but just to say that the responses given by our colleague Phil in terms of the work that all of the unions do to encourage the uptake of the flu vaccination would be something also that we would promote and advocate in SIP2.
That's great.
We would intend and hope that the specific question you raised in relation to the flu vaccination in the context of a second surge of Covid-19 is something that we will have intensive engagement with the HSE around.
Okay, thank you. Just going back to some of the data from the HPSC, and it may have been helpful just to set this out very clearly at the outset. We've all been using the same data from the 11th of July. So we've had 8 of the 26,076 COVID cases, 8,347%, 32% of those were healthcare workers, with 319 hospitalised, 49 admitted to ICU, and very tragically 7 deaths of that. And I think we're agreed as well that 30% of the cases were in a nursing home, residential institution, community hospital, long stay unit. We're all working from the same figures, and only 8.6 linked to an outbreak in a hospital. And I just wanted to set those out. And what we have in a different submission is that the difference between that is likely due to more robust supply chains for PPE in hospitals. But of course, I'm very sensitive to the presence today of Ms Murphy, who, in using PPE, and her colleagues contracted COVID-19 at some point, and you said 12 out of 19 of your colleagues contracted that in circumstances where they had been using PPE in a hospital. Could I just ask one question first, just a policy question, and perhaps I might come back to Ms Murphy in a second. We have separate data that shows that 56% of our nursing homes had no cases of COVID. Could we just talk about those congregated settings, or those intensely populated settings? We also have the prisons where there had been no cases, the Central Mental Hospital where there had been no cases. Have any of the unions got feedback from members in other settings about how those managed those protection processes better, or was it something else?
Well, again, I have been in direct contact with the prison service, and they are to be, and I said this at the last presentation to this committee, they are to be commended in respect of the fact that the prison population were protected to such a degree. And that is not an accident. That is a policy where temperatures are taken, where all of the precautions prior to attending work are, it is to ensure that you're not in any way symptomatic. In the health service, by contrast, the big issue we had with the derogation of staff who were asymptomatic but who had been notified as close contacts. So you get a phone call to say you're a close contact, you should self-isolate for 14 days, and then you get a phone call to say, by the way, we're very short, we need you to come in, have you had a temperature? And when you say no, they say, right, come back to work. That flies in the face of the public health advice. We have sought the removal of that policy. That policy is still there, and no healthcare worker should be derogated by a manager to return to work because they're short-staffed, even though they've been a close contact and they haven't had a test.
I ask,
simply wrong.
Well, how long is it at the moment taking for healthcare workers to get results of tests? Are they all back at this stage within 24 hours for healthcare workers?
It's much quicker. It's improved significantly, but again, it depends on where you reside and where you've had your test. But in general terms, it's very quick.
And may I ask as well? You mentioned that Cherry Orchard had a lab playing a positive role. Do you know now, are all the acute hospital labs being used to try in this way? Have you any update for us on that? Do you know?
I think all of the lab facility is working full out, and my colleagues in SIP2 might be able to give you a better indication. They represent the lab staff.
Yeah, no, in fairness, I think that's correct. All of the lab facilities are working flat out, and I think, as Phil has said, and I think it's evidenced in terms of some of the contributions that we receive back from our own members. The situation as it is today is much improved than what existed at the outset.
Thank you. And this may be a question better targeted at our second session, the HSE later on, but if I could elicit an opinion from you or your own perspective. At this stage, have all the student nurses who will qualify this year, have they been offered full-time positions, not via agency? And likewise, for other healthcare professionals like physios, occupational therapists, all of those who coming out of the universities this year, have they been offered positions? Do you know?
We have an agreement that they will be offered, but it's still a process that hasn't been completed. And I think the important thing for the student nurse population is, from our survey, many of them were traumatised by the experience of going through COVID-19 without supports. And I think we really have to make sure that they don't leave the profession before they qualify. And that's my aim right now. We're trying to get the HSE to understand that they have to support the student nurses who are in training, because there's 1,700 of them graduating this year. We need every single one of them to remain working in the public health service. We're short of our colleagues who come and help us every year from the Philippines and India. We have a reduction in the number of registrations, which I presented at the last committee, through the Nursing and Midwifery Board of Ireland. Their figures show that we are quite significantly reduced over this time last year, and every year the health service and the private and public sector relies heavily on overseas recruitment to supplement our workforce, and we need to make sure that our students, when they qualify, that they're protected, that they're supported, and that they have a permanent job.
Could I ask as well, just we're learning more and more every week, and we had David Nabarro back here so many weeks ago talking about the long-term implications of having had and recovered from COVID-19, and I use recovered sort of loosely because one of the ongoing features is long-term fatigue, and Ms Murphy has alluded to that initially, and again I might come back to that, but just from a policy perspective, do you think there's a need now to review the work rosters or the structures, the sort of the 12-hour shift arrangement is recognising the ongoing nature of fatigue and this illness?
I think the roster, what's required is frequent breaks within the roster. That's what the WHO tell us. We need frequent breaks. For example, and Siobhan is better able to describe this than I am, what is required is that when you are working and wearing PPE, that you are frequently relieved in order to hydrate and to get a break from wearing PPE. I mean, those of you that have experienced wearing masks maybe for the first time will understand that it's not very comfortable and you do feel quite restricted. Imagine wearing that for 4 hours and then getting relieved for your break. So the break period is the important point.
As a simple example, I've had to take three breaks for water from wearing my mask just to do exactly that. So I totally respect what you're saying. Just deliberately putting the policy aside now, if I could come to Ms Murphy with the greatest of respect, and we should have said this to you at the beginning of the session and not the end of it, but I did just want to leave a little space, and of course I come last in terms of questioning. Ms Murphy, you are, I think, we've had 16 public sessions now. And it is my understanding and that of the Secretariat that you are the first person before the COVID committee who comes in to speak to us and to attend with us as somebody who has survived and recovered from COVID. And if I could say thank you for doing that, and it's remarkable that it has taken this long for us to speak to somebody who has actually had COVID. Thank you for coming in. I don't want to ask you in an overly personal way about your experience of that, but recognising that your colleagues have also had similar experiences, having contracted people whom you know well. I wonder if, as we know, for the benefit of this committee and for the benefit of the record of the House, and also for people who may be watching and thinking about what they're doing in their own movements and how they're approaching their interactions with other people, I wonder, could you give us a sense of the general experience that you and those colleagues whom you've spoken to have had about how it is to have the illness without, in your own way?
Yeah, first of all, thank you for allowing me the opportunity to be here today and share my experience. I'm sure a lot of nurses across the country will resonate with what I have said today, and hopefully I've left some impact on going forward how we can improve the service if, God forbid, there will be a second surge. I can speak personally. We went from being a 31-bedded surgical ward to COVID positive ward only overnight. So we had only COVID positive patients admitted to our ward. We took on the task of the full multidisciplinary team as they did their remote reviews of their patients. We were on the ward at the bedside 24 hours a day, and that was an honour to care for patients. We really do. We love our job. That's why we're there. We bridged communication between patients and families using iPads. That's something we never had to do before. We undertook, the list is extensive, I could go on and on, but I suppose the biggest change for me personally and my colleagues who contracted COVID, speaking from my experience, on April 30th, so 6 weeks after we became a COVID ward, I became a statistic where I tested positive for COVID-19. Initially I was upset and quite angry, and that was across the board with my colleagues as well. As I had said previously, that I followed hospital protocol and I was competent in the use of PPE, but the emotions I initially felt were buried by the physical impact of COVID-19. I was crippled with fatigue, bedbound with headaches, I had extreme shortness of breath, which caused great distress as I felt like I was suffocating, and many of my colleagues had the same symptoms. I couldn't talk to my family or friends over the phone, was in complete isolation. I had lost a sense of taste and smell. Simple tasks such as washing and dressing or making a snack for myself was just unachievable as I was completely debilitated. I presented then to the emergency department about a week later as I was deteriorating at home. I was terrified. I have no underlying conditions, as I said previously, so this was a huge shock to me to be the patient in the emergency department in the hospital that I worked in. I was subsequently admitted for what I thought would be overnight observation, maybe 2 nights, and I was kept in for a week. I had a series of blood tests. I underwent a chest x-ray, I had a CT scan of my lungs, I had a CT scan of my kidneys and other organs, just to outrule any potential damage that the impact of COVID-19 can cause. As I've said previously, there is no pattern. For 6 days, I was on a heart monitor 24 hours a day as my heart rate went to 170 beats per minute. They said it was post-viral effects. So at this stage, I was negative for coronavirus, but yet I still had the post-viral effects. Just so the normal heart rate would be 60 to 80 beats per minute. I was on IV fluids, which are intravenous fluids to rehydrate me, and I was on daily injections to ensure that I didn't develop a blood clot, which I have experienced as the nurse. They can be potentially fatal, so that was a worry. The days and nights were extremely long in isolation. Your concentration is affected massively, so even the TV on the background, you weren't paying any attention to it. I was relieved to get home about a week later from being admitted, and recovering in isolation is challenging both physically and mentally, as I previously stated, but I was unprepared for the psychological impact of contracting and living with COVID-19 that transpired. It has definitely prolonged my road to recovery, but I know I'll get there and hopefully go back to work at 100%. For the first time, I experienced acute anxiety, I experienced panic attacks, I have ongoing insomnia. Some nights I can sleep 8 hours, some nights it's 2 to 3. I don't know why. I have vivid hallucinations at the very start with COVID-19, as did some of my colleagues, which isn't spoken about. Everybody speaks about the physical signs and symptoms, but the psychological, as I've said, are just as detrimental in your recovery. 12 weeks on, as I said, still haven't returned to my pre-COVID health. I'm still experiencing some fatigue. One day I'll be fine, and the next I'll need to take a nap in the afternoon. Shortness of breath comes and goes as well, and I'm awaiting a lung function test just to be sure, to outrule that I have no lasting impact of COVID-19. And I also am very lucky that I have physiotherapy input, which I liaise with the hospital to regain my strength to get me back to work eventually.
Thank you. Thank you so much for outlining that for us. We really do appreciate it. And I think it's probably appropriate just to leave it there for the session now. And thank you again, Ms Murphy, and to all of the witnesses. We will take, what's the phrase, take a break and we'll resume at 12:45. Thank you, everybody. Thank you.